Okay, good afternoon, everyone. My apologies for starting a bit late today. This is Winnie Cito, and I think I met you from last antiarrhythmics talk, and now today I'm going to spend some time to update all of you on the medications that we used or commonly used for resuscitation in infants and children. Okay, no conflict of interest. So we will review the goals of medication use in resuscitation, the common routes of medication administration for these purposes, preparation tools in terms of drug calculator that we have developed at SickKids that I know that other centers might have similar tools, the post-resuscitation care using medication infusions, and specific agents, indications, dosages, and side effects. And that I will just give you highlights because I think that the calculator really serves us well in terms of like listing the agents and the dosage. And I think that Cecilia and Carrie planned it very timely because we just got the American Heart Association highlights for the 2020 guidelines for CPR and ECC about 2 weeks ago, late October. So I've tried to incorporate and I've given credit to the publication about this updates. Okay, so the goals of using resuscitation drugs, and I think in general for resuscitation, is to improve coronary perfusion, prevent the recurrence or occurrence of arrhythmias, increase cardiac excitation and contractility so that it's sort of, the contractility is preserved and maintained, correct any acid-base imbalance downstream, and treat seizures, clinical and now also subclinical, and we'll see in the updated guidelines. And they also include condition-specific, like if they have congenital heart defects or pulmonary hypertension, some condition-specific management approach. And I think that through the years, for the past few updates, I think that these last 2 points are relatively new or revised in terms of how we manage subclinical seizures, example, or condition-specific patients where they have comorbidities. What are some of the caveats and highlights for the resuscitation drugs post-rescue? Okay, all right. So let's talk about access to administer medications. And I think it's a challenging aspect, especially in pediatrics area. We do have the routes of IV, but it depends on the clinical status and whether it's in hospital or outside hospital resuscitation event. You might or may not have access to CVL, central venous line. Most often you try to establish at least a peripheral intravenous line. Then failing easy access, we could use intraosseous. It's a rapid, safe, and effective route of administration for medications, and the endotracheal tube. Okay. So let's briefly review that. Venous access in a stressful situation like resuscitation, it's a concern because you do need to get the drugs in. So if it is a peripheral IV access, it's require rapid insertion to be useful so you can start infusing medications. If the patient happen to be having comorbidities or underlying conditions, they might already have a central venous line access. And it's most relevant, especially if these patients are inpatients in-house. The placements, of course, requires training and experience, and it may be delayed if you're waiting for a central line insertion. You're not going to use it for urgent situation like a resus. It's not recommended as initial route of vascular access during emergency because it takes time to insert the CVL properly. Now, if you do have the luxury of both accesses, the prefer and probably common sense to all of you is that to administer medications to central circulation. And it comes to a very strong example with the adenosine, because later on we'll find out that adenosine is very short half-life. And then I mentioned in the antiarrhythmics lecture that, giving adenosine as a life-saving situation like resus, the closest to the patient's heart, the better. So if you have a choice of peripheral versus central, I would prefer that we always use central to infuse these medications, okay? Other medications like calcium, amiodarone, and epinephrine, norepinephrine, they are actually quite irritating. Not only is it far from the heart, and if you have resuscitation event, the perfusion might be subpar, then you really want a central line access. It is actually very irritating to the peripheral vein. And we're dealing with pediatric patients with small veins to start with. So that's why central line, if you have a choice, go for it. If not, then you try the best that you can. And the length of the central catheter might be quite lengthy before it gets to the heart. So, and it can contribute to increased resistance to medications. So I think that it becomes a factor in terms of the type and length of the central catheter. Okay, right. Sorry, somebody's paging me. Okay. Okay. All right. So in terms of pushing through boluses through a multiple lumen central, may be slower than a peripheral catheter. So keep that in mind. Okay. So again, though, most of the time we'll use central just for logistic. So what about if you can't have a good established IV access? All the IV medications, and I've indicated in our resuscitation calculator, can be administered through IO. The key ones being epinephrine, adenosine, fluids, blood products, and catecholamines. The onset of the action of the drug and the drug levels to achieve in the serum are fairly comparable compared to venous administration. And they can also be used to obtain blood samples for analysis, for type and cross, match blood gases during CPR. So it's very convenient and feasible in a resuscitation if you don't have IV access. If you do administer bicarbonate in the IO because it's relatively sort of stuck there, then you try to avoid drawing blood gases, blood work from the same catheter or same cannula for the IO because it will contaminate your acid base analysis. And if we have some thick medications, meaning they're quite, viscosity is high, then you might have manual pressures on infusion pump to get the bolus or infusion through. Okay. After each medication, you follow with a flush because a lot of these medications are sort of cling to the tubing and may precipitate and block your catheter, and that would not be good if you can follow with a saline flush to promote entry, sort of push them in, clear the tubing for the next drug for that dual purposes when you administer through the IO. So it's quite useful, and most of the medications mentioned, I will give an alternative route in our resuscitation calculator. So in an emergency situation, people can refer to the guide and not kind of think about lack of access. Now, what about ETT? It's not as promoted or common as the IO route, but if IO or IV is not possible, and for lipid-soluble drugs, we call the lean principle, lidocaine, epinephrine, atropine, and naloxone. If you have to administer, you can give it through ET or what we call ETT. You see both synonyms in the literature. So now, how do we give it? I haven't reviewed the latest CPR guidelines, but the latest one version that we use is that stop chest compression briefly if you're doing CPR to administer the drug through the ET if you have no IO and you have no IV access. Okay, and then you have to follow a flush with at least 5 mL of normal saline just to clear and push the drugs in, and then you follow with 5 consecutive pulse pressure ventilations. So optimum doses, we actually don't know. It's very seldom studied, let alone in pediatrics. So you might need to end up giving double or tripling the dose of these lean agents, lidocaine, epinephrine, atropine, and naloxone. For epinephrine, a dose 10 times the IV dose is recommended. It seems drastic, but you can think about the anatomy of the ETT and the nature of the tube and the lungs, airways. And it could be challenging because you're trying to intubate this child and it's respiratory distress, then it could be challenging route. But it's an alternative if you don't have IO and you don't have an IV. So how do we proceed to calculate meds? A lot of the times there's resuscitation expression external and not, in hospital arrest, you actually are just estimating the body weight. And according to literature, it's fine because the situation is emergency. A lot of these drugs are titrated response, and you have blood gases and monitoring later on to validate whether you need a second dose or subsequent doses. So we use actual body weight unless in some situation you exceed the adult max, then you sort of go back down and give the adult max dose. And each dose has this unique assessment of what the max dose are. So I've included in the resuscitation guide, dosing guidelines in our formulary either hard copy, electronic, or the resuscitation online sheet, which I can show you later. In terms of formulary, I mentioned hard copy and online, and I'm going to link it to you later on screen here. Then we also have a standard continuous infusion calculator. It's not as updated right now. We need to update it because we launched Epic, but the resuscitation and intubation drug sheets are updated. So at this point, I will try to be adventurous and see if I can actually go to our website, exit out, and show you. So this is our Sick Kids front page, and I have it right here. And for those of you who work at Sick Kids, you might want to go to your own homepage, My Tools, and add resuscitation and intubation drug calculator. Here, personal links. Okay, here. So say if we have like 4.95, you can click as measured, usually it's estimate. Okay. And can everybody, I hope everybody can see it. If not, Cicely can demonstrate to you another time. But you can see the check boxes. And when I started here 25 years ago, I was tasked to develop the first page. Then as people uses it, they like it, they add a second page. And then I think about 8 to 10 years ago, we add the third page. And this year we add the fourth page. Obviously, the resuscitation page is dedicated to resuscitation, but post-resuscitation care for intubation, and occasionally, especially in the outpatient clinics, they have allergic reaction or anaphylaxis reaction to medications. They want a third page. And then the latest, a lot of our code blues might be related to seizures. They asked me to add a fourth page. So let's go. Now, people can unclick it if you don't want to print it out. Our policy is that if we have an inpatient, or clinic visit, and then the front clerk will double check the weight and enter it and print it out, because not every bed spot or location has a computer, connected to access this quickly if needed. And the nurse will double check the weight and his correct name and have second or third copy. First copy is usually at the end of the bed for the patient or on the chair. Second copy is the patient's chart. Now that we don't have a physical chart, it might still be a clipboard or a mini chart from other notes. And then a third copy might go with the patient if they go to IGT or other diagnostic. Okay, it's a lot of paper. And then people say, well, why don't you try to incorporate an Epic? I think that's the future goal. For our purposes right now, familiarity and sort of speed of delivery of the medications, we stay with this. It's online as well. So when you view it, now the font is very small here, but when you print it out in hard copy, is actually the Code Blue team can read it, and that they actually vetted this regenerated or revised version. So you can see, you can click here to print all pages. It has adenosine, okay, like it's alphabetical at this point here. Then you have your volume. And why do we have volume? And I'm telling you this setup is because in your own home institution, if you don't have this already, you might want to build one. We work with the ID team. It's based on HTML. And so it's relatively easy to build with the right IT expertise. So the volume is there because a majority of times in the resus, nurses and other practitioners around the bedside are referring to volume to draw. That's how they can double check the volume. But for the prescribers who yell out the doses in the code, at least you have the dose here to correspond to the volume. So we're talking apples to apples, but the nurse who administers the meds have to change it to oranges because it's volume from the dose, from milligram to mil, so that they can draw up the right volume with the right dose before handing it to the people at the head of the bed to give the medications centrally if they can. There's a bit of comments. Usually these are more for learning and for simulated codes. Really doing a resus code, people should focus on the drug and the volume and the dose. Okay, now you can see some built-in min and max. It's actually built in behind the scenes. If I say, for example, I enter somebody that's like 110 kilo and we have those patient that might be overweight, then you can see it's capped at the max dose. So you're not going to go by just per kilo as per our usual pediatric dosing, but your maximum based on literature, based on AHA guidelines, and based on adults max. Okay, so that's a nice feature to have because then the calculation is done for you in the stressful situation. And you do need to double check the right drug, the right dose volume with the person who drawn up and the person who's double checking and administering the medications. So that's the first page, and you can see the listed medications here correspond to our formulary and correspond to our AHA guidelines. Now, and then the second page, I'm showing them the online calculator. Okay, all right. Another 15 minutes, I think. Okay, all right. So then the second page is actually intubation medications. Although a lot of our units have ability when you run codes to have anesthesia there to intubate, but occasionally people do need to prepare all the meds for them to administer, or for the ICU or the cold blue team to administer. So these intubation drugs, similar concept, are added here. It's been vetted by anesthesia and the critical care units. And then the clinic, mostly clinic, they may have an anaphylaxis drug dosage chart because they might have those reactions. So they only have diphenhydramine, epinephrine with the 1 in 1,000 strength, hydrocortisone, so that they can get going with their sort of, management. Just want to let you know, the latest guideline does reinforce that for anaphylaxis reaction, epinephrine is your first choice. And we are thinking of whether we should move epinephrine to top row to indicate preference, but we also want to defer to the system of alphabetically, listing the drug names here. So that's D, E, and H here. Anyway, the last page is the latest edition, where a lot of the codes are associated with seizures-like event or seizure events. So I've asked to develop and check this. You notice it's a long chart because some of these benzodiazepines has multiple routes, and they might have different dosage related to the specific route. Or midazolam is a good example. You can give it through IM, buccal, intranasal, in this regard. And phenytoin, we have fosphenytoin, we have, levetiracetam, Capra here, phenobarb. So those are the common medications they need for seizure. It might not be a cold blue in that definition, but seizure events are quite common in some of the cold situation. Now, just a caveat, this has all these disclaimer, and it's not for NICU. Okay, NICU has their own specific cold pain medications, but my next edition would be an NICU resus calculator parallel this non-neonate version. So more to come. So I just want to show it to you that this is a homegrown. It served the purpose for now. I've been here 25 years, so this is over 20 years. And over the development of the new guidelines, feedback from users in terms of phase, the format, and the information they find helpful, it comes to grow to 4 pages. And hopefully, I do think that it's something handy, even in this age of technology, to have a piece of paper in front of a blue card for you to draw up the drugs at this point. Okay, all right. So with that regard, I also show you that on here, let's see, 9. Here you also have e-formulary infusion calculator that needs updating. Here, I think I took it out. It's redirected. There is a online calculator that we calculate the amount that you can put in the syringe, but with Epic, which already built in infusions, we tend to rely less on that calculator and more on the Epic ordering. And then the e-formulary, which there's a link and I've sort of mentioned it. Okay, now drug by drug, what should I tell you? I think what I decided to do is actually update for you with the next 10 minutes about the latest update. You might be aware of it, but I want to focus on the medications. So what I suggest is these few slides just outline the doses, okay? And for each of the resus calculator or resus guidelines key drugs. So I think you can read that. What I actually want to focus on. And if you have any questions, you can ask me. Those doses in e-formulary, it's actually incorporated in our online calculator. So in Immuron, we talk about that. But what I did do this year is actually added slides. Okay. Now, before I go there, okay, calcium is a bone of contention with debate on this. A lot of centers have calcium chloride, use calcium chloride. It contains more of the elemental calcium per mil than calcium gluconate, okay? The only issue is calcium gluconate is more diluted. A lot of areas in Emerge or other areas might just stock calcium gluconate. So it's fine, okay? You can use either. There's some older literature that said his hepatic dysfunction might alter the ability of calcium gluconate to raise calcium and release the calcium for boosting up your calcium levels. But it hasn't been really, studied or substantiated. However, in a lot of our critical care units, we actually stock calcium chloride because mil by mil, the volume and the dosage that you need to deliver for calcium elemental to boost up the calcium for the patient is actually more potent in calcium chloride. That's why we stock it and we use it. If you do only have peripheral venous access, you all know that calcium is very irritating. You might end up using calcium gluconate with appropriate dilution because calcium chloride is just so concentrated. You do not want to give it calcium chloride peripherally, especially with the risk of thrombophlebitis if you can avoid it. Okay. Now, what about the latest guidelines? Okay. So those are all the doses listed there. The latest guideline is this one. I include the reference there. It's an excellent piece of information. So recapping for the pediatric basic and advanced life support, where I really care about as a pharmacist is the middle part. I defer your high quality CPR to you, but the medications is give early epinephrine for patients in non-shockable rhythms. Early epinephrine, this is a highlight. Early is the emphasis here, as early as possible, improve the survival likelihood. Another aspect, and although we don't think about it as much, is opioid overdose. It happens in adults, it happens in pediatrics. Inpatients likely less because we double check everything with opioids, but it's possible. You might have a decreased clearance or metabolism of opioids, or renal impact, and you might give naloxone as opioid overdose. It could be a medication safety event. But outside of the hospital, or even, visitors, we have found, some cold blues, although they're with adults, that have opioid overdose in our vicinity of the hospital. So people need to recognize opioid overdose, and naloxone should be used. Now, airway management, I'm not going to do that because it's part of the pocket cards in the whole slide deck. But one of the things that I want to actually focus on is this. So the next few slides, I know it's a big slide stack, the 37 onwards, I copy and paste the guidelines but highlight for you. Early epinephrine, how early? Administer first dose of epinephrine within 5 minutes from the start of chest compression. This is the first guidelines for many years that they mention 5 minutes specifically. It's any setting, doesn't matter in-house, outside. There is a study within hospital arrest that for initial non-shockable rhythm, asystole or PEA, every minute of delay is decreased in return of spontaneous circulation and decrease in survival and decrease survival to discharge. So early means less than 5 minutes if you can. Okay, so this just is comparing the old and the evidence. Okay, the other second caveat or highlights or pearls is you must treat seizures. Clinical, you can see it, you'll treat it, but subclinical. They recommend continuous EEG, detect seizures, look for them following cardiac arrest, especially with patients with persistent encephalopathy, they need to sort of come back. Treatment of clinical seizures following cardiac arrest, and reasonable, very reasonable to treat non-convulsive status, epilepticus following cardiac arrest, and that's why the continuous EEG is important. But you need to, of course, consult with experts like neurology to make sure any further scans needed, etc. Now, condition-specific changes this year is the septic shock. You have the fluid boluses here. Now, vasopressor choice. People debate, is it epinephrine or norepinephrine? I think it's whatever you can get your hands to. If you're familiar with epinephrine, give it. If you only have norepinephrine in your hands, then give it as an initial vasoactive. What about the vasopressin? It's been floating around for past couple of guidelines. It's not recommended with the level of evidence. However, if you're in an ICU and already your fluid boluses, you've given epinephrine, norepinephrine, steroids, you might progress to vasopressin. But that's once you're under the care of critical care, initially with resuscitation. What about steroid? For infants and children with septic shock, unresponsive to fluids and requiring vasoactive, you might consider stress dose steroids in terms of a refractory shock. Okay, so that's the highlights and emphasis for this year. What about opioid overdose? That's not a condition specific, but sort of like an indication. Patients known or suspect to be in cardiac arrest in the absence of a proven benefit from the use of naloxone, standard resusc measures priority over naloxone with a focus on high quality CPR. So it says that if you have a suspected cardiac arrest or known, so if you don't think it's benefiting because you don't think opioids is a high suspicion, then of course the standard CPR takes over. However, if you do have some suspicion with opioid overdose, you will give naloxone. Okay, you can give with a partial reversal or you can with full, depends on the history. So this is sort of their general statement. Now, including this cut and paste, I have myocarditis and other conditions, but the medication focus out of this page was the opioid and naloxone overdose, naloxone in the treatment of opioid or suspected opioid overdose. Other recommendations that are specific, which I thought is actually very nice highlight, with single ventricle pulmonary hypertension, not so much with meds, but more in terms of focus management. Now, these algorithms are all there. I have to give them credit. I find them helpful to be around. I might investigate in terms of pocket cards for our fellows to investigate and, having the front line, having these cards. There's a checklist as well. I find it interesting that they want to make sure that post-arrest, in the post-stressful period for staff and patient and family, we have a complete checklist to make sure nothing is sort of missed. For example, if you gave a stress dose steroid, is there underlying endocrine conditions you need to address post-arrest? What about post-arrest IV access, post-arrest infusions for the medications, weaning of some of the inotropes? What about antibiotics, cultures, and drug levels after a sepsis, resuscitation event? So those all are things that we should not forget. Now, this is a level of evidence, so I'll just include. So I really strongly recommend. I think they really did a good job in terms of the highlights and need to know. I actually read the full version. It's actually shorter than the original, 15 years old version when they first came out. Sick kids, drug formulary, and I will be updating. Another update was that I think they updated a couple of years ago is the role of amiodarone versus lidocaine. I don't think it's a versus now. It's actually last guideline. This one say they both have a role. Okay, so it depends on your institution, your own experience. They are not saying amio is superior to lidocaine. There used to be a period when amio seems to be favored over lidocaine, and now both have enough evidence, or perhaps lack of good evidence, to be sort of head-to-head to be a choice. So I apologize that I did not include the slides going with them side by side about the doses. I think that you can use as references. The best is actually the e-formulary, hard copy, or actually the online calculator as a tool and reference. So it's all there. But I thought that it's more timely to emphasize the medications update and revisions incorporating our latest October 2020 guidelines. And the guidelines that I actually download is a Canadian edition. I'm not sure if they have a US edition or in your country a different type of guidelines. I did check for the purpose of this talk, the European guidelines, and I don't think they have updated as this 1 month old document. So hopefully give you a tool to use, an idea if you don't have that tool already, or ideas to improve the tool. If you have any improvement ideas, tell me, because it's a perpetual pet project for me that I feel very important for resuscitation and patient care. And number two is refer to these highlights. And if there's any questions, you can directly email me or Cecilia. Any question?